Hi, and welcome to my presentation. My name is Elizabeth Webster, and this is called Navigating Trauma Therapy. I personally decided that I wanted to use the title of Navigating Trauma Therapy with the idea being that many times for us as therapists and helping professionals, as well as clients who are seeking help with trauma, previous traumas that they've experienced, etc., it can often feel like a maze. There are many options, there are many tools in the therapist's toolkit, as well as many symptoms and other issues going on. And so, how do we navigate the needs of the client, the myriad of different available modalities and therapeutic techniques that are out there? And how is it that we decide which ways that we would like to take our work? So let's go ahead and get started. There we go. Okay, so first of all, I just want to start with the basics. When I say the basics, what I mean is that it's so important for us to have a very basic understanding of what it is that trauma is and what trauma can result in when it comes to an individual and their resulting disorder or struggles or daily dysfunctions that they are seeking help for. So, for example, one of my favorite quotes regarding trauma, which I feel truly does encompass much of what the DSM dictates trauma is by Friedman. And it says a catastrophic event or a series of events in which individuals have been exposed to situations in which they were personally threatened or witnessed threatenings of death, physical harm, sexual violence, etc. That is trauma. So that's a very basic understanding of trauma. That's, I feel, a good comprehensive definition of trauma. But one of the things that I truly enjoyed about this course in specific was Dr. Shapiro's work. Dr. Shapiro, as we'll get into, was the founder of EMDR, and I'm movement desensitization and reprocessing therapy. And in her work, Dr. Shapiro made it very clear that there's a distinction in her view between what she called small t trauma and big T trauma. Now, here's what's important to keep in mind. Trauma is a wound. Trauma is a wound that has happened to an individual. It does not necessarily have to be something that will cause a diagnosis or a diagnosable disorder, but trauma is something that an individual has undergone that has caused them pain and has caused a wound, and they need help from. Small t trauma, in Dr. Shapiro's view, would be traumas that do not necessarily result in diagnosable disorders afterwards. That does not mean that they don't require help and that therapy cannot be a useful tool to processing that trauma. Large T traumas would be those things that can cause diagnosable disorders afterwards, such as PTSD, anxiety disorders, other traumatic stress disorders. I think this distinction is very important. First of all, because sometimes in my own personal work, I've encountered clients who what they experienced wouldn't classify as a trauma via the classification system within the DSM. What they experienced, the DSM would say, was not traumatic necessarily. They didn't witness death. They weren't threatened with death. They weren't threatened with physical harm or violence, but instead, possibly, they went through life as normal and something unexpected happened that has resulted in a struggle for them, and they feel that they can't come back from. An example of this could be, for example, a horrible breakup where they were cheated on. And maybe that's not necessarily considered a trauma by the DSM standpoint, but that would be considered trauma from Dr. Shapiro's view, that is still something that's causing pain, and that is still something that is causing hurt, and maybe they feel like they just can't get past that breakup, and it's still something that therapy can help. Now, post-traumatic stress disorder, on the other hand, which would be arguably the result of big T trauma, um, obviously that's something that this course has focused quite a bit on. And post-traumatic stress has gone through different renditions of what it was understood to be. We have, obviously, in the history context, PTSD being originally shell shock. It was found after soldiers coming back from war who were completely in a different place than they had been when they went the first time, when they went over to the war. Um, PTSD is typically, there are 4 cluster symptoms. You have intrusion symptoms, avoidance symptoms, alterations in mood and cognitions, and then alterations in arousal and reactivity. So you have the pretty classical symptoms of PTSD, I think, that most people would argue for, would be flashbacks, nightmares, avoidance of certain triggers that would remind them of previous traumatic events, depression, anxieties, and hyperarousal or hypervigilance, where the individual is constantly on edge, paranoid that something is going to happen, that they have to continue to protect themselves. Now, personally, I'm very interested in some of the research going into hippocampal differences with individuals who have PTSD, as well as just in general the neurophysiological sides of PTSD. Um, and some of the work that has been going into, for example, even looking at Bessel van der Kolk's work, looking at those different sides of PTSD. But unfortunately, for the sake of time, we don't have the time to go over all of that in this presentation. But I do, one of my favorite books that I've ever read um, is called Why Zebras Don't Get Ulcers. And it's all about stress and trauma and how the physiological responses that we have from said stress and trauma. And that was one of those things that really, when I first was exposed to that text, it really brought an understanding for me of what was beginning to form as sort of the basis of my um, current framework of counseling with individuals. So that brings us to the current framework. I come from a psychology background, obviously. I'm sure as many of us do, but specifically, I'm a social psychologist. I did my degree in undergrad in sociology and psychology, and then in grad school, I was studying under Dr. Jenny Gutzel in the Social Interaction and Motivation Lab at Brandeis University. And Jenny, my advisor, Dr. Gutzel at Brandeis, she was a neuroscientist by trade. She's not a psychologist, and she brought me into her lab because up till that point, most of her work was from a very neurocentric view. She did some fantastic work with in-group and out-group. But there was a gap in the understanding of how the psychology of individuals was being impacted on a deeper level. It's one thing to look at a study and say, we can see that there's a neurological response to this situation, this social situation or environmental situation. But it's something different when we can start to begin to look at the psychological depth of what is happening in these situations as well. I began to find myself gravitating more and more towards schools of thought that focused mainly on individual development being shaped by all the different factors around us, everything from the past, family and friends, future hopes, faith or lack of faith in any religion, culture, environment, environmental changes, and looking at things from a sociological standpoint of how the overall group is interacting and impacting the individuals within that group to either assimilate or dissimilate them from the culture and the overall group whole, to how it shapes the individual and possibly shapes the individual's thoughts of self, that really began to shape the way I wanted to help individuals. And it was through that time too that I realized I wanted to be doing more practical, more hands-on therapy work rather than research. And I also began to find myself fascinated with the idea of cognitions and how they would impact behavior and possible change. Another technique, I guess you could say, that I was exposed to in that time was reflective listening, and how we can motivate change through truly just tapping into the thoughts already that an individual might be having, but help them motivate themselves forward. And that really pushed me into what I would say is my current framework of therapy, which is, traditionally speaking, cognitive behavioral theory, or cognitive behavioral therapy, CBT. Um, I have been fascinated by the idea of this triangulation of reactions and interactions between cognitions, behaviors, and emotions, and how, looking at the historical research, everything from B.F. Skinner's operant conditioning theories of modifying behavior to even Bandura's Bobo doll experiments, where Bandura really did a lot regarding social learning theory and how behaviors, when they're modeled for us, begin to teach us how we feel or how we should, quote unquote, act through the world. When you combine that with just basic operant conditioning, where you've, from again, from B.F. Skinner, you have this idea of the conditioning through repeated um, reinforcement from consequences, either negative or positive, so rewards and punishments, as well as modeling through Bandura's theory of changing behavior or changing even thoughts. And that was where really I would say even Aaron Beck sort of took things a little step deeper, where he began to incorporate thoughts into the behavior theories that were, and the learning theories that were kind of big at the time. And this was when Aaron Beck truly began to look at developing a theory to help individuals with depression and how they could take dysfunctional thoughts and modify them, and how they could create change in these depressive disorders and begin to cause change for the positive. And then there was Donald Meichenbaum, who, I have to say, Donald Meichenbaum is probably one of my biggest influences in terms of cognitive behavioral therapy, because he truly modified and combined all of these different theories from Skinner to Beck to Bandura, and truly designed a therapy, CBT, that would aim at modifying maladaptive self-talk by looking at developmentally where these negative cognitions can be targeted, the behaviors they result in, and the emotions that cause distress, and how this trifecta of um, cognitions and behaviors and emotions, how these three impact the individual into causing disorders or into causing struggles, essentially. Um, and it was really through, I want to say, I'm fascinated with history, and it was through multiple history of psychology courses that I found myself gravitating towards CBT. And as much as I love and enjoy the CBT model, as the years have gone on now and my work has continued, um, it's a little reductionist in my estimation. I think that CBT certainly does scratch the surface of what is needed when it comes to helping someone, but it is quite reductionist in the view of how simple it views helping someone who is truly struggling with um, pretty severe disorders. Um, That does not necessarily mean that that doesn't negate its efficacy at all, but I think that it's the height of hubris for us as therapists to reduce down an individual to simply say you are a result of modeling and social learning your thoughts and behaviors and emotions. And although these are important steps in the right direction to modifying in positive ways, I have found many times where I felt that CBT fell short of the ultimate goal. So, with that being said, though, as I personally came to faith when I was in college in my undergrad years, I realized, looking back, part of what I believe drew me to CBT once I was a new Christian in grad school looking at all these different techniques and theories, once I realized I wanted to go into therapy and into counseling. And Romans 12:2 is one of my favorite scriptures where it tells us to do not be conformed to this world, but be transformed by the constant renewal of your mind, that by testing you may discern what is the will of God and what is good and acceptable and perfect. CBT allows us to test. It allows us to use testing to discern what is the truth and what it is that the Lord has for us. And I mean, CBT in its essence is a testing of thoughts and previous patterns of thinking that are dysfunctional and painful and problematic. And it is a way, it is a tool for us to transform our minds as we are told to in the scriptures. We are told to not be conformed to this world. And at the heart of CBD is the idea that we are influenced so much by social learning that the world is trying to conform us to its view of thinking. And that is not who we are called to be as believers if you are also a Christian. And our dysfunction does come from the world. We live in a fallen world. We, in the Christian view of belief, as I ascribe to, we live in a fallen world which models wrongdoing. It models indulgence, and it models um, looking out for number one, selfishness, pride. And we are commanded to shed those old ways and pick up our new man and our new way of living. And so, too many times, I feel like I have heard Christians and non Christians alike say things like, excuse me, say things like, we'll just stop doing that. Or, you know, why don't you just stop that? Why won't he just stop that? Why won't she just make that stop? And that is also where we are doing each other a disservice. CBT is a great tool. It's a great practical tool. Um, but from a Christian perspective, CBT is, again, like I said before, it's limited in its scope and how reductionist it is of the humanistic view. Um, there's not enough of credit given to interpersonal struggles or introspective issues when it comes to CBT. Not everything can be pointed out as a result of something we modeled, because ultimately, in the Christian view, the inner man is sinful. Yes, like I said before, we have been born into a fallen world, but we also are fallen. That is why we needed a savior in the Christian view. And so there has to be more to what we can do um, to help, to help our clients, um, to help those who come to us seeking care. All right, so this was what brought me to seek more. This was what brought me to seeking more from what I could provide for my clients. So it was this background in CBT and then resulting work that I have done with clients that brought me to a place where I was seeking more in terms of education and what is available out there to use with clients and how to help clients. Um, and through this journey, I have so enjoyed being exposed to different therapeutic techniques and different um, empirically proven and supported therapeutic modalities. So, um, the first one that specifically through this course and a few courses that I've been in previously that I was really drawn to first, probably because of my background in CBT, was cognitive processing therapy, CPT. I I like to tell people that although I'm not a neuroscientist, that was not my background fully, working in Dr. Gutzel's lab, I feel as though I was exposed to a different side of the neuroscience behind psychology than I ever would have been had I not taken the position with her and studying under her. And I was truly blessed by her and her perspective. And one of the big things that she and I really sort of hashed out together was this view of memory processing and reprocessing. She was very she was working very closely with a couple different cognitive neuroscientists, and they were doing work in Alzheimer's research specifically. And when I first saw cognitive processing therapy on paper, I was fascinated with the shift from behavior focus, as in CBT, to memory processing and how we process the thoughts and the stuck points that we have from our traumas. And so, a basic overview of CPT, as we have seen, um, if you also have been looking at CPT during this course, but if you haven't, as in depth as if it wasn't your chosen modality to study, CPT is very, very similar to CBT, but like I said before, it's a stronger emphasis on the processing of those traumatic memories versus the behaviors that are resulting from uh, stuck points or cognitive um, thoughts that are problematic. It's a very structured program, 12 weeks, similar to most work with PTSD. It was originally developed to help out with veterans, and um, the continuing education piece that we were offered in this course also was through the VA. Like I said, it's very structured. There's a 12-week process to it. There are different protocols of CPT. There are CPT A plus, and that's where there's a written trauma story that the client is asked to provide to the therapist versus simply just retelling of their trauma. Its goals, there really, I would argue that there's three main goals, which through reading Rezik, Monson, and Chard's book, and on the references of this presentation as well, there are a few other articles by Rezik and Chard specifically, where they discuss in more depth sort of their goals behind creation of CPT. But truly, the number one goal is to discover these stuck points. So these stuck points are the thought that the individual has that they are stuck on. It's a thought about themselves, about the world around them, uh, their own ability to function in the world, and it's something that has tripped them up over and over again and is causing problems and dysfunctions in their world. Um, the second goal I would say would be to remove the symptoms of PTSD. Um, these stuck points, in the view of CPT, stuck points and the repeated rumination on these stuck points has pushed the individual into PTSD. That's a little bit of a simplistic way to sum that up, but essentially that is the view. It's that the individual has become stuck in a certain pattern of thinking based on the trauma they've experienced, which, because of the repeated stuckness, essentially, for lack of a better word, the repeated thinking on that stuck point has caused PTSD, or has at minimum caused the symptoms of PTSD. As we know, PTSD specifically for diagnosable disorder must have been going on for at least a month. It must be removed in time from the time of the trauma event, so it's a later reaction in a sense. And PTSD also can be very complex. There is complex PTSD, CPTSD, and then there is also a CP or PTSD that can respond very quickly and efficiently to therapy, and then there are some that doesn't. And so a goal, the ending goal of CPT is to create more accurate and positive thinking that is processed into the view of the self in place of those stuck points. And that's done through education, basically psychoeducation regarding PTSD and what the process of CPT looks like and how we deal with trauma. Also homework, so very similar to CBT in that way. And if you read the text that we were given in this course, the Rezik, Monson, and Chard text, cognitive processing therapy for PTSD, there's wonderful examples of some of the worksheets that can be used and are used in CPT with clients, specifically the challenging questions worksheets. I really, really enjoy those and how it goes into depth with challenging those stuck points and identifying them as well. In addition, processing of emotions is a important part of CPT. Retelling of the trauma and being able to articulate in a way what happened is very important for individuals who have been traumatized. And in the view of CPT, that's a therapeutic process, is the retelling of their trauma. Also, obviously, identifying those stuck points. And there are worksheets as well in the text that I've previously referred to that walk the client through identifying what their stuck points are. And then there's the next stage of replacing those stuck points. Maybe the stuck point is, I will never, I'll try to think of an example. Maybe the stuck point would be, I will never be able to do this, or I always mess things up. But ultimately, we want to, which, that would cause emotions of anxiety and distress and depression and all these things. And so ultimately, the goal of CPT is to bring them to a place where they challenge that thought, they challenge that stuck point, process the emotions and the resulting impact that has in their life, and then replace that with a new thought that is positive and true, and is something that they can really hang their hat on and they can really hold on to feel the truth and put things into the perspective they need to be in. Which then brings us to the second, and this was actually the primary empirically proven treatment for trauma that I wanted to focus on whenever I came into this course. To be honest, before coming into this class, I didn't know a lot about EMDR. I didn't know a lot, I mean, I knew it involved eyes, and that was about it. But through this course, through reading Dr. Shapiro's book, that EMDR, and through continuing education seminars that I was able to participate in on EMDR, I have been so encouraged and blown away by this process. Dr. Shapiro, the story goes, it's a little bit more legend than story, but even in her own book, she does share this story. She was walking along and was having some distressing thoughts. And she noticed that if she moved her eyes in a fast paced bilateral movement, similar to REM sleep, um, those distressing thoughts seemed to become less distressing. She was desensitized to them. And as her research began, as she began working with veterans and testing out these theories, she began to find that through this process of bilateral stimulation specifically, and her original process was through eye movement, that not only were they desensitized, but they could reprocess the trauma and essentially the stuck point, similar to CPT, and replace it with a new truth about themselves. Um, Now, for the sake of time, EMDR is one of those therapeutic techniques that, as someone who has just briefly been exposed to it through this course, can go so in depth. There are 8 phases of EMDR, each with an intentional focus and intentional goal of identification of what the stuck points would be, um, processing of that, coming into a place of replacing it. It uses different techniques like the SUD scale, where individuals in therapy are asked to estimate how true something feels for themselves in terms of the distress that they're experiencing. Um, and all of a sudden, through looking at EMDR, and specifically, I did participate in one of the seminars for our continuing education portion, where a focus was brought between simply the benefit of bilateral stimulation, not necessarily eye movement. So many EMDR therapists now actually will do this same technique, but they use sounds that are presented differently in the ears in a bilateral way, tapping on either the client's knees or wherever there's comfortable for them, essentially. Um, and the way that the way the brain is the way that this stimulation is activating these memory processing m- mechanisms and the systems within the brain to be able to bring those memories back up, desensitize the individual to them, and reprocess them into a more beneficial view of the self and the situation, and not necessarily to replace and say the trauma never happened, but to be able to bring that person from remembering something that they've previously encountered that possibly they would have said was a 10 out of 10 on the distress that it was causing them, and to bring them to a place where it's now a 2 out of 10 on distress that it's causing them. That's huge. It's not that we want our clients to pretend or come to a place where they don't believe the trauma ever happened. We want them to be able to look back on their lives, acknowledge what has happened to them, but it doesn't invade their present or their future. And EMDR is one of those that has been repeatedly shown to be beneficial for this. And so all of a sudden I began to realize the cognitive CBT, sorry, CBT and CPT, there's too many, um, really focuses on the behavior. And I do still believe that behavior is a huge part of how we develop our thinking about the world around us, ourselves, and our responses to trauma. So you have the behavior portion in CBT, which I've always ascribed to. Then you have the actual memory and thought process that's very well hit on with CPT and the way it processes those memories and those stuck points. And then you have this third technique, EMDR, that really begins to incorporate the way the neurological side of our brain is reacting to our memories and where those are stored and how they impact our emotions. And to this day, EMDR is still debated about how exactly it works, but it's not debated that it's been proven effective. And all of a sudden, I was seeing that these three techniques really do incorporate together in a really wonderful and beautiful way. And then, as I was watching one of these seminars, the the presenter was talking about mindfulness and how mindfulness or grounding techniques, whatever you want to call it, just means to return to awareness. And I think that is so key for us, especially from my standpoint as a Christian, that when we are working with clients who have suffered or currently suffer with PTSD, they've got to be brought back to the awareness that what's happened in the past has happened, but it does not control the now. And so from my viewpoint, all three of these techniques, CBT, CPT, and EMDR, especially in corporation with mindfulness, represents a renewal of the mind. Just like I said in the beginning with Romans 12:2, we are called not to be conformed to this world, but to be transformed by the renewal of the mind. Our thought life is very important. It's no coincidence that we are commanded in Scripture to consider that which we think on, to renew our mind in the way that we view the world around us. In addition, we must center on truth. Philippians 4:8, one of those other scriptures that I feel is so indicative of what it means to be a Christian. Finally, brothers and sisters, whatever is true, whatever is noble, whatever is right, whatever is pure, whatever is lovely, whatever is admirable, if anything is excellent or praiseworthy, think about such things. So when we challenge the stuck points, when we bring in a new statement about ourselves through EMDR, about the client, we're centering ourselves on the truth. Because the truth is, in the Christian view, in my own personal view, is that the Lord has created every individual for a specific purpose. And the enemy tries to steal that from us. He's a thief. He comes to steal, kill, and destroy. But when we recenter our mind, when we renew our mind and center it on the truth of what the Lord has brought to us, it can help us also to bring focus. And as I was drawn to mindfulness specifically in partnership, I guess, with, you could say, with CPT and EMDR, as a modification specifically, there's a lot of debate out there regarding mindfulness and grounding techniques. Specifically, in the faith communities, sometimes it is seen as something that is not of God, because it does come out of the Eastern religion practices, and that's not something that can be denied. That's not something that can be debated necessarily. But that's not the only place it comes from. I had the privilege a few years back to travel around Italy. And it was a wonderful opportunity. And we got to go to some of the oldest monasteries and cathedrals in the area. And one day we were walking around, it's called Monte Cassino. It is this beautiful old monastery. And the monks were chanting. And to somebody from an outside perspective, who I had only been a Christian for, oh gosh, maybe 2 or 3 years at that point, it looked like they were meditating. I don't know if at that time, if someone hadn't, if I had not known the context of what I was walking into that monastery, I don't feel that I would have known that this was any different than Buddhist monks who I had encountered during a summer that I spent living in India for an internship slash mission trip type thing. Not a Christian mission, but just a humanistic one. And I realized as going through this course, and I began to get more and more interested in mindfulness and specifically just simple awareness of what's around you in the room, in the space. What do you hear? What do you see? What do you feel? What do you smell? Or even the whole idea of mantras, especially in EMDR, where um, many EMDR therapists will encourage their clients to have some kind of truth statement or safety statement that they repeat to themselves when they first start out, when they're first identifying what their body is feeling. And, I hear the term mantra, and as a Christian, I instantly sort of go, like, that's not, I don't know about that. But as I was walking around, and I kept being reminded of this monastery, and as I was walking around this monastery, Monte Cassino, I was so struck by the repetitive nature of the chant that the monks were saying and the peace that it brought to the space and the focus. And I've had opportunities and friends from different Christian backgrounds, from different denominations essentially. So Catholic, Episcopalian, Methodist, all across the board. And I've asked them about their view of mindfulness and what they understand about it. And one of my dear friends, Mike, and his wife shared with me that in their estimation, it's prayer. Now, what you are praying to, that's your decision. But chanting a scripture over and over again, as those monks were, or repeating a mantra like, God loves me, or just simply being aware of the nature of God's creation around you, whatever that process looks like, even simply just being aware of your physical body, just progressive muscle relaxation, even. That is a way of being in the present with what God has created and what God has intended. And that is so vital to any therapy that we do. We want to help clients to renew their mind by centering on the truth and focusing in a new way, pushing back all of the pain, pushing to the side all of the distractions of the world, and bringing their focus and attention to Christ. And saying, this is where I choose to place my attention. So what does that mean for my current clients? Well, currently I work at the Life Center in Midland, Texas. That's where I'm from. And to sum it up very briefly, we are a pregnancy resource center here locally. We service, oh goodness, probably about 38,000 clients every year, just in Midland, in our office here alone. But we do have 3 other centers, satellite centers, that we are getting off on the ground right now. And part of my job there is, first of all, community outreach. I do a lot of community psychology focused work, and then working with clients. And the bulk of my clients who I see are in some kind of sexual crisis. They've just found out they're pregnant, or they're scared that they might be pregnant. And they typically 9 times out of 10 come from a poverty background, very socioeconomically challenged, and I have yet to have a client who did not have some sort of traumatic childhood event. And they are scared of what that means for their future. And many times they don't even realize it. And I am so encouraged by what CPT and EMDR and mindfulness can bring to my clients. Most of the time now in my work at the Life Center, I I have the opportunity to counsel from a Christian perspective. That's what we do. Does not mean that the person is necessarily always a Christian, but they know that we are a Christian organization, and so they have that understanding. And there's a beautiful respect for those clients who I've worked with who are not Christians. Yet I've noticed that regardless of whether someone is a Christian or not, when we start talking about the past and what thoughts they're stuck on and what emotions they cause and what behavior patterns they've fallen into to cope with those traumas and the distressing emotions they currently feel, it doesn't matter your faith background, your current standing, you want help. And so I am really excited by the expansion of my own knowledge. In no way do I feel like my journey of expanding my understanding of therapy is done. I feel like I've only begun to scratch the surface at that. But I am so excited to see how I can begin and continue my journey to incorporate these things in the right context with the right clients to continue to help them and to take it a step further than what I was providing previously. Um, I'm really excited by this entire opportunity with my current clients. So moving forward, in summation, I want to start wrapping it up here. I want to continue my education. Obviously, I am still continuing on with Liberty University. I will be finishing up with my degree here in the next few years, fingers crossed. Um, but I want to continue specifically my education regarding more of the in-depth side of um, what incorporation of CPT and CBT and EMDR, what those look like when they begin to be incorporated, what other therapy modalities are out there. Because I really do believe, as I'm sure we've all kind of experienced through this course, that we can't try to fit a client into one specific modality. We have to be open to modification based on the need of the client. And we can't modify if we have a myopic view of what we should be using to treat people. So I am excited to continue my education in that way. I'm also excited to incorporate some of these new techniques. I've already begun to talk with my own supervisor at the Life Center about some of the techniques that I saw or that I was exposed to through the EMDR webinars. Obviously, not EMDR centered itself in the sense of I'll discuss that in the next slide. But techniques such as progressive muscle relaxation, techniques such as breathing, just simple breathing techniques to ground, which I feel that we probably have all heard of grounding techniques, but one of the ones that in one of the webinars, she asked us all to participate in viewing from home, was just simply sitting in a room and becoming aware of the space around you and noticing things. Not to think about anything specific unless you wanted to, but just to view and be aware. and the calm that it brought, because I found myself becoming aware of the birds outside the window and the nature that the Lord's created. And so I'm interested, I'm very excited to begin to incorporate more of those new techniques. I'm also very excited to begin to use the worksheets and the provided um, forms from the CPT text that we have, specifically the challenging questions workbook. Um, that is something I already have a couple of clients who I could see where CPT would be a benefit for them. I have not decided yet regarding the written trauma retelling or not, but it is certainly something that I've been exposed to CPT before. My supervisor actually um, tends to use CPT quite a bit. She used to work with the local VA here, um, and I'm excited to begin to learn more from her and incorporate it more into my own work as well. And then I hope to do future certifications. I would love to become certified in EMDR as an EMDR therapist. Um, Although I'm fully aware that I don't believe that I will ever be one specific type of modality therapist. I think we have to all be open to learning as much as we can and discerning through the Holy Spirit what it is that our clients need. And that doesn't mean that in the future I won't have some clients where just CBT tends to work, doing the ABC worksheets, and there we go. And then maybe there will be ones in the future who need EMDR. And I am excited by the opportunity, because as we continue our education journey and we broaden our horizons, to use a very well used metaphor, but as we do broaden our horizons, the Lord will open doors for each of us as we need. And I'm excited by that opportunity. I truly, truly am. So I want to thank everyone for viewing this presentation. I I really have enjoyed this course, and I really have enjoyed getting to make this presentation for you, getting to share my personal theory or emerging theory of therapy and how this course has helped me to develop that. And I have so enjoyed getting to learn from each of you through our discussion boards, through our reflection journal assignments, etc. And I thank you for this time, and I wish you all well and safety and blessings during this pandemic in our world. And I thank you very much.